Welcome to Grand Rounds, both on Zoom and media site. We haven't gotten too many people here in the auditorium, but I'm looking forward to possibly making Grand Rounds live here in the near future, and we will let you all know with that. For now, we'll continue our usual protocol that you send a question in through Zoom or through the button on media site, and we'll ask those questions at the end. If you could ask them during the talk rather than waiting to the end because there's a little bit of a delay. It's my pleasure this morning to introduce Catherine Mealy, who was kind enough to agree. I almost had to go take her kids to school or do some sort of, to get her to come because I needed a speaker for this date, but she happily arranged that as well. She's going to give it, she trained at Tufts for medical school and then went to UCLA for the combined pediatric and internal medicine. We were just talking about it, residency. There's not a lot of those in the country, but she did one of them for 4 years, and then she went to Hopkins for her fellowship, and she's going to talk to us about the updates and changes that we've all seen, and they've been going on for some time kind of in a progressive way over the last 3 or 4 years, and she's going to update us and tell us how to manage that. So, Catherine, thank you.
All right, thank you so much. Can you hear me? So I'm going to try to go quickly because there are a lot of updates, so bear with me as we go through this. To start out, I have no disclosures, except for the fact I gave this talk to my 3 children last night and it put them promptly to sleep. I hope it has a better effect on my colleagues. I'm going to start with a quick case. So this is actually someone I saw in clinic about a week and a half ago. An 81-year-old male was sent to me. He had a really distant 10-pack year smoking history and quit a while ago, and he was presenting with exertional dyspnea and even some dyspnea at rest while talking. He had a stress echo with no concerns for ischemia, normal wall motion, normal LVEF, and he was sent to Pulmonary to see if there was something else going on. He did have a known elevated left hemidiaphragm that he'd had for years and hadn't caused any problems up to this point. So he does feel winded while talking, as I mentioned. He's up at night with symptoms about once a week, sometimes a cough, sometimes shortness of breath. He has some sputum in the morning. He does feel a little bit of anxiety. He actually has benzos prescribed, and he'll take them intermittently for shortness of breath that he feels is related to that anxiety, but that's different than that symptom he's feeling at night that's kind of waking him up. So we did get pulmonary function tests on him, and I'll walk you through here the important information. So you'll see at the top, FEV1 and FVC. Looking at that ratio, his was 0.65, which is below the lower limit of normal. So he does have airflow obstruction. And then all the way on the right, the percent change is going to be important when you look at the FVC and FEV1. So if you look at the percentages here in the middle column, he's got a 38% predicted on his FVC and 34 on his FEV1. So his lung volumes are small. That's likely his elevated hemidiaphragm, but he does have improvement in increase in the size of his lungs with the bronchodilator. So there is bronchoreactivity. There is a component of airway reactivity going on here. So he should qualify for treating this underlying airflow obstruction. So I'm not going to answer this question right now. I will at the end of the talk, but think to yourself, which inhaler would you prescribe for him? We'll go over the classifications of asthma. He's kind of a step 2. We're going to give him a short-acting bronchodilator, a SABA, which is albuterol, a long-acting antimuscarinic, which is like Spiriva, the LAMAs, or an ICS with formoterol scheduled, an ICS with formoterol to use as needed, or an inhaled corticosteroid with an albuterol as needed. There's a lot of options, and what we would do now is very different than what we would do a couple of years ago. So to kind of outline what I'm going to go through, basically the NIH gave us our stepwise approach to asthma in 2007. And that was kind of the mainstay in what we've been going off of for a long time. In 2019, there was a big update from GINA, the global initiative for asthma, and that really changed what we were thinking about in treating the asthmatics. It wasn't until 2020, just at the end of last year, when the NIH gave their update. So I'll go over those guidelines because they're kind of discrepant at this point. Briefly, I'll go over how do we diagnose asthma. And then based on the guidelines, how to use inhaled corticosteroids, ICS with formoterol or a LABA, and then LAMA inhalers, and then when to refer and what we're thinking about on our side on referral, so you really know what kind of patients to push towards referral. I'm going to talk about COPD as well. I might go a little bit quicker through this section because the updates are not as significant, except for management at a higher level. So there's a lot more options for COPDers who are very severe and have more severe disease. So starting out with asthma. Here is our 2007 chart of what inhalers we used back then. And if you notice at the bottom, those are our combined inhalers. We have Advair as a disc, Advair as an HFA, and Symbicort. 3 things. And then everything on the top is basically a version of albuterol. Just looking at the slide, it's gotten more busy. There's a lot more options. There's new drug companies, there's new inhalers, there's new combinations. It's harder to get a grasp on what we should use when. So hopefully through this talk, you'll get a better idea by just me highlighting some of these. Again, like I talked about when I went over the outline, so the NIH has the NHLBI, the National Heart and Lung and Blood Institute, which put together the National Asthma Education Prevention Program Communicating Committee, which is a mouthful. So I'll just refer to them as the NIH. And then we have our Global Initiative for Asthma, the GINA, which is more of our global guidelines. So the differences between the two are kind of, it's pretty dramatic. So GINA is all specialists. So it's all pulmonologists focused in asthma, whereas the NIH guidelines actually incorporate primary care, public health experts, implementation scientists. So it's a great group of people to really figure out what fits for our country and our nation and what the resources we have available. However, their updates are periodically, and by periodically, they gave us a recommendation in 2007. We have a ton of research. We didn't get updates until 2020, and actually most of those updates are based on data review that is from 2018 and back. So there's 2 more years of a lot of data that's not included in those updates. Whereas GINA gives us annual recommendations, so it's a lot more taking the pulse of what's going on in the literature. So there's pros and cons to both recommendations, and understanding that kind of will help you guide therapy. So the focus of the 2020 NIH updates were these 6 topics. The fractional excretion of nitric oxide testing, I'm not going to go over, or the bronchothermoplasty, because we don't do either of those things here at Virginia Mason. The FeNO testing, they really are just saying, hey, use it in context of the rest of the clinical picture, which makes sense. And then the bronchial thermoplasty, they're really saying, well, let's not do that unless it's in a study, because it doesn't have good data. The other things, though, there's a lot of data for, so intermittent inhaled corticosteroid use, or ICS, long-acting muscarinic antagonists, and indoor allergen mitigation, and immunotherapy for allergenic asthma. So those are the 4 things I'm going to focus on from their update. This is just a list of the topics that they didn't cover that they were hoping to get to in their meeting. So there's just a lot out there, and they're pretty slow on giving us the recommendations, so this is just to give you an idea of that. So diagnosing asthma, we all know the person who comes in with chest tightness, wheezing, cough, shortness of breath. What both NIH and GINA are really trying to push is getting objective data on that airflow obstruction and variability. Now, it's not always possible, but these are the 4 best ways to do so. So their spirometry can have bronchodilator reversibility, so their FEV1 or FVCs changing by 12%. Or greater with using an albuterol, or if you see a lot of variation just through each time they have a test. Another way to do is a peak flow diary. A lot of people, when they come in for their PFTs, they're not having symptoms, so we're not going to catch it. But if we're doing a peak flow diary at home, then we can see that variation. Greater than 20% is considered significant. We also do therapeutic trials. Just try the inhaler, follow your peak flows, or get another FEV1. There are times where I try the inhaler and just see symptomatically, are they dramatically improved? But you really want the, yes, I feel totally different, instead of the, I think so. Because they're really trying to get away from using inhalers if we don't really know it's asthma. And then bronchoprovocation is great because it's high negative predictive value, meaning if it's positive, they have asthma. The methylcholine or mannitol inhalation challenge, and we can do that in our PFT lab, or in asthma and allergy, actually. So this is just to go over what has been true since 2007. As a pulmonologist, I use these words all the time, but it's easy to forget how we classify everybody. You can do it by symptoms during the day, nighttime symptoms, how much they're using their inhaler, how much it interferes with activity, or even lung function. But just to simplify things, we'll kind of focus on daytime symptoms because that's what most of the studies use for how to classify participants and which step to put them in. If you're only using your inhaler about once a week, up to twice a week, you're an intermittent asthmatic. If you're almost every day, but not every day, like more than 2 times a week, it's a mild persistent. Daily use is moderate, and then severe if they have symptoms throughout the day. They're also intermittent and persistent are commonly referred to as step 1, 2, 3, and 4 asthmatics. So, and you'll see that when I refer to some of the studies that actually classify people this way. So this was our NIH 2007 recommendations, and it was so easy. Okay, they have asthma, but they're just symptomatic once or twice a month. Okay, give them a short-acting bronchodilator, give them albuterol. Step 2, okay, they have a little more symptoms. We're going to give them a low-dose steroid and albuterol as needed. And then from there, you add the long-acting bronchodilator, then you increase the dose of the steroid, and then from there you refer. So it was add one thing with each step. Fortunately, we've found out that although this is simple, it's not actually addressing the issue, and asthma is a little more complex than this. So 2019 is when the first big change came out. So GINA published their recommendation that short-acting bronchodilators are no longer recommended to be used alone. Instead, they recommend it using symptom-driven inhaled corticosteroid combined with a long-acting bronchodilator, specifically formoterol, because its onset is quick, like albuterol, but it lasts longer. So this was a big deal. Their update, they modified the steps. So now our step 1 is using as-needed low-dose inhaled corticosteroid and formoterol, and just whenever you need it. Take it to work, put it in your pocket. Make sure you rinse your mouth out after you use it, even if you're in the middle of your workday, which is a little caveat, not hard to do. But that was their first recommendation. Step 2, you're going to use your low-dose inhaler, and then the combo on top of it, which is that if you're doing that, you're actually prescribing 2 different inhalers. So they also said it's okay to use just keep doing what you did in step 1. Use the inhaled corticosteroid combo with formoterol as needed. And then step 3, use it scheduled twice a day, and then as needed throughout the day, and so on. The reason for this change is because we know that in mild asthmatics, persistent short-acting bronchodilator use is bad. So theoretically, there's a lot of basic science research that shows this. So using SABA alone is associated with downregulation of our beta receptors, decreased bronchoprotection, and reduced hyperresponsiveness to the albuterol later on. It increases asthma response. So if you have an allergenic asthma, they're using albuterol all the time, they're going to be more sensitive to their allergens. And it increases your airway inflammation. It actually increases the eosinophils in your airway. There's clinical data that shows if you're using SABAs a lot, you have worse outcomes. So if you're dispensing greater than 3 canisters a year, it's associated with a higher risk of ER visits, and greater than 12 a year is associated with a higher risk of death. So as a global organization that's trying to address an issue that varies by country and access to care, it was a good idea for them to say, let's just not give this, and let's give an inhaled steroid that reduces the inflammation with a long-acting bronchodilator. And I'll go through the data for that in a minute. But before I do that, I want to contrast that to what the NIH came out with at the end of 2020. So despite the same data, they're recommending for step 1, still use a short-acting bronchodilator. It's just too much to get an inhaled corticosteroid for someone to be using intermittently. On step 2, we're just going to do a low-dose inhaled corticosteroid with as-needed short-acting bronchodilator, which is the same as it was before. Or you can use a combo, which is the same twice a day or as needed throughout the day. The step 3 for this was similar to what we saw in GINA. But in order to really help everyone reconcile the two organization's recommendations. I'm going to go through things step by step and show you the data behind it. So first, starting with step 1 and step 2. The data that really changed using the short-acting bronchodilators and now using the long-acting bronchodilator was actually an AstraZeneca study that was done primarily in South Africa, but also Europe, Canada, pretty much everywhere but the U.S. Symbicort is an AstraZeneca product, so it was called the Symbicort given as needed in mild asthma trial. Now these mild asthmatics were actually more step 2, mild persistent. Some of them might have classified as intermittent, but so you're less severe asthmatic. And they did 2 different trials. There's Sigma 1 that looked at 40 people, about 4,000 people around age 40, and Sigma 2 is over 4,000 people ages 40. And the 3 different groups that they looked at, for Sigma 1, they did a triple 3-head comparison. So placebo twice a day with terbutaline PRN. Terbutaline is the AstraZeneca version of albuterol, which we don't use here in the U.S. And group 2 was placebo twice a day with the ICS formoterol as needed. And group C was budesonide twice a day, so Pulmicort twice a day with terbutaline or version of short-acting bronchodilator twice a day. So I'll go over the Sigma 1 results first. So looking at blue is terbutaline, red is budesonide as needed, and then the green or black, whatever color it is the budesonide maintenance. And as you can see, the blue line at the top is a lot higher in this curve for severe exacerbations. The y-axis here is looking at the probability of having a severe exacerbation over time on the x-axis. So if you're in the just terbutaline group, you're more likely to have an exacerbation compared to the as-needed combo or maintenance combo, which are the same, decreasing the exacerbations. When you look at symptoms, though, the budesonide maintenance group did win. So if you ask patients, are you symptomatic daily, about 40% felt well controlled in the budesonide maintenance group compared to 20 to 30% in the other 2 groups, the as-needed inhaler groups. And that makes sense. If you're preventing it from happening versus catching it when it happens, you're going to feel control or not. The main takeaways from the study: improved asthma control. We have improved asthma control with the inhaled corticosteroid formoterol compared to SABA. So it is better. Like this study showed it. However, this was more of a step 2 than step 1, but some of the patients did really cross over, and we were in both those groups. Daily ICS has better symptom control than the combo, but the combo inhaler is non-inferior for acute exacerbations compared to a daily ICS. And really importantly, if you use it as needed, it results in less cumulative inhaled corticosteroid dose, which is kind of intuitive. Looking at the Sigma 2 study, it's the same thing, but just looking at 2 of the arms, so placebo with Symbicort or the maintenance budesonide with short-acting albuterol, and it really was no difference, so non-inferiority. They did show, though, better symptom control on the left. You'll see this is the y-axis is the symptom score compared to weeks. And the symptom score is better in the lower in the scheduled budesonide group compared to the as-needed. And the FEV1 improved in the as-needed ICS formoterol group by about 80 mLs, were improved by about 120 in the maintenance group. So our takeaways here are the ICS formoterol as needed and the maintenance, it's the same, non-inferiority as in terms of exacerbations. The benefit as needed is we had 1/4 of the amount of ICS exposure, and the benefit of the daily ICS was that there was slightly better quality of life scores and slightly 20 milliliter difference or improvement in the FEV1 that was statistically significant. So the NIH tried to rationalize why they were keeping SABA for step 1. So they had said, they cited a study that was a post hoc analysis of these 3 studies that really looked at about over 1,000 patients over 12 years. And they thought that the combined ICS with PRN, the using it as needed to reduce exacerbations, they agreed that that happened, that it really did reduce exacerbations. However, if you look at the mildest, so the closer to step 1 than step 2, if they really differentiate those two, the improvement was marginal and not statistically significant. However, this review that they cited for their reason to keep the SABA there in step 1 did not include the Sigma studies. This review was published beforehand, and they didn't actually include either of the two studies I talked about in their references for their update in 2020. So is there going to be another update? Are they going to change this? It's still to be told. What we do have, though, is the national recommendations are helpful because our insurance companies don't cover prescriptions for as-needed ICS formoterol. So what are we doing clinically? For me, if I do it depends on the patients. You really do have to think, who is this person? If they fall into the step 1 or step 2 patient, some of them, I'm just going to give them a short-acting bronchodilator. I'm confident they're not going to overuse it. I'm confident they'll reach out if there's issues. If it's someone who I'm not confident will reach out, I really do want them to have a combo inhaler because I don't want them to use that SABA too much and then get out of control, even if it's just maintenance. And then you also have to think about cost. So a lot of times Symbicort or Dulera, which are our ICS formoterol inhalers, aren't covered by insurance. So instead you're prescribing a Flovent with a short-acting bronchodilator take together. And then they have 2 inhalers they're supposed to walk around with as needed, which isn't as practical. So it's become a little more of an art right now as we still tease out in the data what is best, and insurance companies catch up with what the data is showing. So moving on to step 3. So step 3 actually agrees in the 2 different groups, Argina and NIH, which is nice. It's a recommendation to use single maintenance and reliever therapy, the SMART therapy. So use your Symbicort or Dulera twice a day, and then add as needed throughout the day as your rescue inhaler. This, on the left here, this figure, the line at the bottom shows FEV1 for someone who's taking placebo every 4 hours. The sawtooth curve here shows someone who's taking their FEV1 for someone who every hour during the day, for someone who's taking short-acting bronchodilator albuterol every 4 hours. And as you can see, their FEV1 is seesawing. Right after they take it, it goes up, and 4 hours throughout the day, it comes back down. And then the top line with the diamonds is someone on a long-acting bronchodilator. It improves their FEV1 and their airways stay open for the rest of the day. So this seems like a good idea. It actually is working. So there was a great meta-analysis that looked at 16 RTCs and 22,000 patients. It had more moderate persistent asthmatics than it did mild, so more people in that step 3 group. And they compared the association of using the SMART with exacerbations requiring steroids, hospitalizations, or ED visits for people over than 12 versus the same dose of that inhaler just as a maintenance with a short-acting bronchodilator. And it favors using the SMART therapy. So everything to the left of that vertical line on the right side means that study favored using the SMART technique. This is the same thing. They compared the SMART to using the higher dose of inhaled corticosteroids. And it's not as you can see, the top study crosses the vertical line, so it's not significant there. But otherwise, the composite of all these studies together, we did find statistical significance that the SMART therapy is better than even a higher dose of inhaled corticosteroids. So some caveats to the SMART therapy, however, is that the majority of the studies use budesonide formoterol, which is Symbicort. You cannot do this with Advair, which is inhaled corticosteroids and Simeterol, because that, like I said before, it's a slow onset of that bronchodilator. So you have to have the right inhaler to do this. Maximum dose is 12 puffs a day for someone. Honestly, if they are taking 12 puffs a day, they need to call you because they need better control. So I don't think that's really a drawback. There's other treatments that are needed. Also, powder inhalers don't work as well for this. The HFAs, or the hockey stick-shaped ones, work better because they have better shelf life. The discs, or the powders, 3 months, and you haven't used it, it's solidified and you can't really use it now. So it depends on what inhaler you have, whether or not it would work. And you also have to recognize the patient. If it's someone who never takes their inhaler because they're like, I feel fine, but then it just accumulates until they have an exacerbation. They're not going to recognize that they needed it as a rescue. So maybe that's a bad person to have them on an as-needed inhaler. And like I said, just to highlight, you can use this with Dulera or Symbicort, but not with Advair. Okay, I'm talking a little fast, sorry, but I'm trying to get it all in. So the LAMAs. Now this recommendation to add a long-acting antimuscarinic was for, in the NIH recommendations, was for step 3 and GINA step 4, but in that way it's 6 of one, half dozen of the other. If they're not controlled on a combined inhaler, try adding a LAMA in. And this data really comes from, there's multiple studies, but this one published in 2010 in New England Journal is pretty well done. It's a smaller study, only 250 people, but they did a double-blinded triple crossover study. So over a year, they had people in 3 different groups. Everyone was on an inhaled corticosteroid, and then they either added on tiotropium, another dose of inhaled corticosteroid, so doubling their dose, or Cimeterol, the long-acting bronchodilator. And each person had 14 weeks and then a 2-week washout period to try the different inhalers. Oh, one thing I want to mention, the patients that were selected for the study all had confirmed bronchodilator reactivity. So they went to the PFT lab, they took albuterol or Atrovent, and their FEV1 improved. So that means the patients were kind of pre-selected to do better on a bronchodilator. So that is a critique of the study. But that being said, we did see that there's non-inferiority to adding tiotropium when compared to adding Cimeterol. So as you can see here, the top left, or box A, is the morning peak flow, was higher in the tiotropium and the Solu-Medrol group. The evening peak flow as well. The FEV1 was even higher in the tiotropium group, even compared to the LABA group. And then the asthma control days, the symptom controls, were better in the bronchodilator groups compared to the double steroid groups. So the NIH recommendations for this ended up being, do not replace your LABA with a LAMA, but it's a good idea as an add-on. So step 3 or step 4, we can be adding that on. And there's actually good data for adding it on to just an ICS sometimes if the patient can't tolerate LABA. Okay, moving on to indoor allergens. So these are things that you think about are patients that have moldy apartments, they have cockroaches, there's tons of cats, or they're just not changing their bed sheets enough. This is something that I get commonly in clinic, so I just wanted to bring it up because I'm sure all of you will at some point. A 47-year-old female with moderate persistent asthma. She's currently on the SMART therapy, so her scheduled and PRN inhaler is the same. And she's normally on steroids about once every other year, so well enough controlled. She was wondering if it's worthwhile to buy the newest HEPA filter, which is about $1,000, because she's heard it can help asthmatics. Her symptoms are the same inside the house as they are outside the house, and when she travels, they don't change. So do we tell her that's a great idea, go ahead and invest? Do we send her for allergy testing? Or do we tell her to save her money for her co-pays on inhalers because, gosh, we know those are really expensive. So we're not going to really tell her that, but that's the gist of it. I'll go over why allergy testing is not really indicated for her. And specifically, there's no good data. I love HEPA filters. I'm an indoor allergen person or indoor air pollution researcher. So they're really great for some things. They're really great at reducing the particulate matter when there's a fire. But if you're specifically being asked, should I get this because it will help my asthma, the data isn't there for it. So when thinking about indoor allergens, we want to remove specific allergen exposures only if there's evidence of sensitization and exposure to that allergen. And removal strategies should be part of a multi-component allergy-specific mitigation. So they can't just do one thing. They can't just put a cover on their bed to avoid dust mites and then call it a day. So basically, do we send them for allergy testing? So for this woman, she had symptoms all the time. There's nothing specific in her history that said, yes, this is probably an exposure thing. So if there's no history, we do not do any further testing. However, if there's histories of a lot of mold in their apartment, or they went down to the basement and it got worse when they lived in their friend's basement, then we would think about sending for allergy testing. I'm going to go through the NIH updates had a really nice table with some of the common allergen interventions, and I'm going to go through them and let you know what the summary of the data is. So acaricides, which I actually didn't know this word before this talk, so killing the dust mites doesn't actually work. Putting on a pillow covers or mattress covers can be helpful. There's actually moderately good evidence that for our dust mite allergen people, they should do this. Getting rid of the cockroaches. There's actually good data that this can help, moderate data, sorry. It's low certainty of the evidence, but there is some data to show that. Carpet removal, unfortunately not good data to show that for asthma. HEPA filters, not good data to show it helps in asthma, but our certainty there is low. There is possibly some good data for pediatrics. So think about that twice if there's an asthmatic child in the house. There is good data that HEPA filter vacuums actually in pediatrics, and that's with moderate confidence. And then removing the kitty cat, it's actually, data goes both ways. So it really depends on how much it's going to hurt them to get the cat out of the house. But yes, if they have a specific cat allergen and they have a cat at home, then that's probably going to be a good intervention. But the data still it goes both ways. So when to refer? So if anyone's at step 4 or 5, we're going to start thinking about immunotherapy and biologics, which I'll touch on briefly. So we really want to make sure they're seeing a pulmonologist by then. If they have frequent exacerbations, if they have eosinophilic asthma or high IgE, we want to refer because they may even qualify for biologics at that point. If they have aspirin-related exacerbations, or if they need steroids a lot, they're basically step 4 or 5 at that point, and we want to see them. The things we're thinking about are what comorbidities are we going to control at that point. Obesity, acid reflux, OSA, and sinus disease all contribute to asthma, so mitigating these things are really important, and sometimes teasing them out and how much they contribute is easier to do in the pulmonologist's office, and then ruling out everything on the differential. So going into what the referrals of the specialists will do. So our partners in A&I are great here. So immunotherapy, there's some good data for this. So immunotherapy is therapeutic administration of exogenous aeroallergens to a person who demonstrates sensitization with the goal of attenuating the individual's asthma response to subsequent exposures to those allergens. So meaning I'll give you little doses of this so that it won't be a big problem when you're exposed to it in the environment. The people we want to refer for something like this are the people who it's pollen season and their asthma gets really bad. They've got a good clinical history, and first they have to have a positive skin test or RAS testing to say, yes, there is an allergy here. Now, the NIH has looked at this. We do subcutaneous and sublingual treatments. The sublingual treatments are actually not as great for asthma. So the NIH has agreed with using the sublingual immunotherapy and said the subcutaneous therapy. The sublingual therapy, however, is not recommended in asthma treatment specifically. And here's a summary of that. It's both with conditional and moderate evidence. Moving on to the biologics. This talk could be like a 3-day workshop, so I won't get too into it. There's a ton of data. It's really blown up over the last 5 years, and even there's a study Katie Horan pointed out to me this week that I'm able to include. Thank you, Katie. That came out this week that's really exciting. So these are the biologics. It's a busy slide. What I want you to take from this is mainly type 2 inflammatory cascade. So most of our biologics are trying to stop that type 2 inflammation. The IL-5 is like fertilizer for eosinophils, so we're trying to stop the eosinophils from propagating this whole cascade. Dupilumab is IL-13 and IL-4 inhibitor, which does affect eosinophils, but also affects our Th2 cell to B cell interaction and nitric oxide. And then omalizumab is over far on the right, which is our IgE mediator. So if your patient has high IgEs and symptoms of allergies, they're going to be a good patient for omalizumab or Xolair. So it reduces the IgE by about 96%, which causes reduction in mast cell degranulation. And the evidence is really great in kids, both safety and efficacy in children. And we've seen that using this in kids during flu season, they actually get less asthma attacks. So there's thought to be something between the respiratory viral infection and your asthma flare that makes it so effective during cold season, during the fall. The indications is add-on for moderate to severe asthma, anyone over 6 with positive skin testing or in vitro reactivity who's not adequately controlled by ICS. So this one's even indicated if you haven't added on other inhalers. So it's kind of similar. The patients who'd benefit from this could be similar to the patients who'd benefit from immunotherapy, just kind of to think of it that way. There are some nuances there, but that's a big picture idea. Are there eosinophils high? No problem. We can take care of that. We have 4 drugs to do it, and they're great. And they're now sub-Q injections. And most of them can be covered by insurance, or there are programs to help aid for them to get it. So definitely refer, especially if there's high EOs, even if they seem well controlled, because sometimes there's persistent daytime symptoms that we're unaware of. So yes, anyone who's step 4 or 5, sometimes insurance companies want to see if they're on all the inhalers possible before we take this step, because they are very expensive. And the first step is to delineate the history of exacerbations. They should be having at least one a year. So you'll see a lot of our notes will have their exacerbation history written out in the note that we copy forward for each other note. We get a full pulmonary function test, and we, of course, are addressing comorbid factors. This table just kind of summarizes what I've gone over and the delivery. So most of them are subcutaneous. Resolizumab is IV only, but I don't think that's FDA approved in the US, and I've never used it, so don't worry about that one. The far right is the benefits. So the ozolizumab reduces the IgE. It has the most safety data in children. All of our IG or IL-5 inhibitors, in general, depends on the study, there's about a 50% reduction in your exacerbation. Benralizumab or Fasenra also shows to decrease oral steroid use and improve lung function. So there's good data for that. Duplibimab, I really like this one. It has the strongest data for reducing exacerbations, improving lung function, reducing daily steroid use, and even reducing nasal congestion and nasal polyposis. So this is something that it could even work in our the allergy or the aspirin allergy and nasal polyposis patients, as does Fasenra or benralizumab. So what if you don't have eosinophils or IgE? Well, a week ago, I would say, stop, we don't know yet. Well, but luckily, tezolizumab has been, now this is the phase 4 trial to prove, they went through phase 1, 2, and 3 was published, phase 3 was published this week. This is all I know about it. It's a human monoclonal antibody that blocks thymic stromal lymphoprotein, which is an endothelial cell-driven cytokine implemented in the pathogenesis of asthma. To be honest, I'm not an expert in this, so I don't know the details of it, but I do want to point out on this slide, it's on the left here, it's not necessarily, it doesn't interact in just the type 2 inflammation. It also interacts in type 1 inflammation, and that's why it's great, because it's not just going to get our eosinophilics or IgE patients, it's going to get other ones as well. And this is a great paper published in New England Journal. So they had about 1,000 patients and randomized them to the intervention or control arm. The patients all had to have about 2 exacerbations a year that required steroids. In the teplizumab group, the intervention group, the exacerbations once the medication was started decreased, and there was only 0.9 over the year versus 2 in the placebo group. And the adverse events, you'll see 77% compared to 80%. It was pretty comparable, and the severe adverse events was only 9% compared to 13% in placebo group. And then nicely we show there's a change in the baseline FEV1. So as you can see, the blue line is the placebo. Interestingly enough, the placebo patients did have improvement in their FEV1 of about 50 mLs. The intervention group had improvement about 200 mLs in their FEV1. And this table is the cool part. So most studies of our IL-5 and our IgEs talk about people with eosinophils greater than 150. So that's 0.15 on our manual diff on the computer. So this one, they stratified it based on their eosinophil levels. And if you look at that second column, less than 150 eosinophils, everything is to that left of the vertical line, meaning it favors the intervention. So we had significant improvement and decrease in the rate of exacerbations. To give you an idea of the side effects, I just printed out, this is from their supplement table. These are the different side effects that we're seeing. Mainly nasopharyngitis was most common. As you can see, they're pretty much the same. The symptoms we're seeing in our intervention compared to control group are pretty much the same. So it really seems like a low side effect, except this nasopharyngitis was the most common thing. So wrapping up asthma in a nutshell, try to get objective data of airflow obstruction when we're treating someone. Avoid frequent short-acting bronchodilator use without ICS. The sooner you start the ICS, the better probably, and the SMART therapy, so using the same inhaler as long as it's formoterol, not Advair, twice a day and then as needed is recommended. Add on a LABA and be sure to refer because we have immunotherapy and biologics that are becoming a lot more mainstream. We're going to see patients on more often. So briefly going into COPD. Now, GOLD, there's no national working group for COPD, which actually makes it easier, so we only have to follow GOLD or the global recommendations. But the NIH has said that they're coming up with a COPD action plan. We define COPD by non-reversible obstruction. It's normally caused by exposures, and I have just a table of potential exposures here. This figure is probably familiar to a lot of you. So we used to go classify people based on their FEV1, which was objective data. Now, GOLD, the Global Institute for COPD, or GOLD, is global. So a lot of times in resource-poor settings, we can't get FEV1. So they made a big push to push it, the classification more towards symptom-based. This also helps, I feel like, treat my patients because a lot of times they don't act like their number on the test. So on the far right, you'll see our symptom-based square, group A, B, C, or D. So group A and B have 0 to 1 exacerbation a year, and C and D have more exacerbations. And then AB and BD are divided by how symptomatic they are daily. So the MMRC and the CAT are the two questionnaires we use to help identify daily symptoms. So the MMRC, we basically ask them, how symptomatic are you with XYZ activities? The place I kind of start is number 2. Can you, when you walk with someone your age, are you able to keep up with them, or are you walking slower with them then? If they can keep up, then they're 1. If they're walking slower, then they're 2 or 3. And then you can specify the questions further from there. The CAT questionnaire is great as well. For each cough, phlegm, chest tightness, shortness of breath, limited activity, confidence leaving the house, sleepiness, and energy level, you scale on 1 to 5, where do they land? And if the score is greater than 10, then they're going to be group D or B on the right side of that square, Punnett square. So it's important to identify which group they're in because that helps guide what treatment they're going to be on. So this is a summary of what our COPDers should be on based on their group. So the group A, if they're not really symptomatic, I have some COPDers that have like pretty significant obstruction, but they feel nothing. You can just give them a as needed short-acting bronchodilator. A lot of those people who feel nothing, though, especially my older patients, I'll say, let's just try Spiriva, let's try a LAMA, and see if it improves your symptoms. Because a lot of these people have lived with their COPD for years, and they don't know they're limited. They use their Spiriva like, whoa, I didn't know I was short of breath. So give it a try sometimes. The action potential there is hard depending on the cost. So Spiriva and all of its buddies, Incruise, they're expensive. So if they can't afford even a trial of the inhaler, then I say just skip with the short-acting if they don't have exacerbations. Now, if they have more exacerbations, I want you to add on the a LABA and a LAMA combo is recommended. And really the update that has happened over the last few years is pulling away from using inhaled corticosteroids. So there's only specific patients with COPD where we want to use corticosteroids. We're going to use it more in asthma and less in COPD. So inhaled corticosteroids, GOLD supports use if there's history of multiple hospitalizations, so they have a lot of exacerbations, greater than 2 a year, if they have high EOs, or if they have a history of asthma as well. So those are the patients we want to use it for. We do not want to use it if they have repeat pneumonia, low eosinophils, or a history of a mycobacterial infection. Stay away from the ICS if that's the case. And then in the middle there, if they're kind of somewhere in the middle, go with your gut. It could kind of go either way. This table just shows the research, what outcomes are affected by different inhalers. So we do have data that symptoms, FEV1, and exacerbations can all improve with these inhalers. And I'll direct your vision to the middle of the table. So LABA-LAMA combo can improve symptoms, FEV1, and decrease exacerbations, just as well as the ICS-LABA-LAMA combo. So the data is actually really the same there. So adding that ICS on, really, we have to know what the benefit will be there. And then at the bottom, roflumilast and azithromycin, those are things to think about in our chronic exacerbators. And I'm going to go through those medications really quick. This one, in Washington State, I've gotten this covered for 0 patients. I know that some people can, but roflumilast, there is initial phase 3 publication in 2005 that there's moderate improvement in FEV1 and nonspecific changes in exacerbation. And it really is for the chronic bronchitic type. So considering your severe COPDers who have a lot of phlegm and a lot of exacerbations. A cheaper option is azithromycin. So it can also be used in our frequent exacerbators with a lot of phlegm and sputum production. And Dr. Horan has given a good talk on azithromycin before. Maybe we should have her back for that again. But it has a lot of uses and could be used here as well. Gold wanted to emphasize the same way Gina does that we want to continually reevaluate the patient. So a review, assess, and adjust the treatment. So this circle here is a lot like what you'll see the Rethink It circle from Gina. And then this is another figure I liked, just showing, this is also from Gold, showing if you have a dyspneic versus a frequent exacerbator. On the left, the chronic dyspnea patient, you see how the ICS-LABA, the arrows are moving away. This patient is not going to necessarily benefit from ICS, so we're kind of moving away from using ICS just because you're short of breath. However, if on the right, if you're a frequent exacerbator or if you have high EOs, then let's give ICS a try. If that doesn't work, we'll add on roflumilast or azithromycin. So when to refer? There's a lot of new stuff, especially interventional stuff that's going on in COPD. So if you have advanced disease, if you're group C or D, bullous disease or emphysema and symptomatic, we want you to refer. And this is the Gold slide that they included for why, because there's a lot of options. And if you just look at the bottom, you can get a bulectomy if we have really like bullous emphysematous disease, or lung transplant, or lung volume reduction procedures. So there's surgical and bronchoscopic versions of this. And I'm going to focus on the bronchoscopic interventions here. And this is information from Dr. Seberg, but both him and Dr. Kirtland can perform this for our patients. So it's important to know we can do this here because it can really make a difference for some patients. So it's lung volume reduction that's achieved through placement of a valve into the airway. And it causes atelectasis that reduces the volume in that part of the lung to open up the good part of the lung so we can actually aerate part that has alveoli still. It's a highly selective process. And let me tell you, I know from watching my partners, they're very safe about who they choose because we want good outcomes with this. There are 2 main valves we can use. These are pictures of them. They're kind of cute, but the patient won't see them. They're inside the lung. So who should be considered? So our severe COPDers. These are sick people, FEV1 less than 50%. if there's emphysema on CT or X-ray, they have to stop smoking or be willing to stop smoking. And then they're going to have to participate in pulmonary rehab. There's a lot of nuanced criteria, but if anyone kind of is that you see in clinic is on this spectrum of patients, we want to see them so we can get to the nitty-gritty of patient selection. A lot of people think, oh gosh, this patient's really sick. They're not going to be able to go through a procedure like this. Well, those sick patients are actually the ones that benefit from this. So that's the ones we want to see. A lot of them have resting hypercapnia, severe bronchitis, but there are cutoffs. So if this is kind of the list of who to include and who not to include. If they've had a history of lung surgery, then it could be harder, and we won't be able to reduce the lung because everything fibroses. But please, if you have questions about these patients, Dr. Seberg and Dr. Kirtland, I've asked you to reach out to them. Dr. Seberg's newer here, but on paternity leave right now. So for 6 weeks, you'll have to reach out to Steve, but after that, you can reach back out to Luke. So in a nutshell, asthma, like I went over, finding objective data, reducing our albuterol use and increasing our ICS use, and using the ICS sooner, adding on a LABA and referring for immunotherapy and biologics. And for COPD, we want to use less ICS, so we're going away from using Advair as our go-to and more Spiriva. And identifying the phenotypes can help direct treatment further. And be sure to refer because we have a lot of advanced therapies. And I'll stop for questions.
5 minutes. 5 minutes faster than you thought.
Yeah. Okay.
Can you make sure this is working? Got it. Okay. Thank you. That was great. I have a question, and then I'll ask Jolene if she's got any. Could you review a little bit about what the side effects of the inhaled corticosteroids are, and then anecdotally tell us what you see in your practice?
Yeah, thank you. That's really helpful. So, side effects of the steroids, the main one being thrush, a hoarse voice, and the side effects are directly proportional to how often they're using it. So one of the big drawbacks to the SMART therapy is we're asking people to take it up to 12 times a day. Like, they're going to get thrush. Because the more you use the inhaled corticosteroid, or the higher the dose, the more likely that is to happen. And it's hard to have people, if they're using it as a rescue, to have water available to rinse their mouth. So that's a big caveat and a drawback in that recommendation. So I have patients that I have to treat thrush multiple times, and we just decide we're going to pull back the inhaled corticosteroid and do a lower dose so they can still be on something. I have better luck when I use HFA compared to the dry powders, and using a spacer sometimes can help, because then it just, with the slower flow in, get deeper and less be on the back of their tongue. I do have some patients anecdotally, even on inhaled corticosteroids, without a LABA, have had increased heart rate, feeling overwhelmed, like a really dramatic symptoms, and those are my high sensor patients that have symptoms with every medicine they're on, so I take that with a grain of salt, but it's mainly the thrush that I see in clinic as well.
So no worries about systemic, patients ask often about systemic side effects to inhaled.
That's a really good question. What I tend to tell the patients is, so 10% of what they've done studies, and 5 to 10% of what you breathe in is actually absorbed into circulation. So that's what I tell them. So we think about being on an inhaled steroids, you're getting a tiny dose because it's just 5 to 10%, versus are you going to end up needing systemic steroids repeatedly? That's what we're really worried about. So that's kind of where I'm trying to give them, help them agree with me on where the balance is better. I don't want them on a ton of steroids, but I haven't seen issues, and I would defer to one of my colleagues. I haven't seen much data with changes in DEXAs related to ICS use, but I haven't looked at that specifically. But I try to reassure them just that only 10% is absorbed, and then our goal is to reduce the amount of systemic steroids you're on.
Jolene, do you have any questions at this point?
I don't have any questions. I do have a comment from Dr. Katie Haran, and she says, fantastic news. Thank you, Catherine, for this whirlwind tour of asthma care.
Yeah,
And I did get one more question.
Okay, good. Yeah, sorry it was so fast. I was trying to get a lot in.
Why do COPD patients have increased risk for pneumonia, but asthmatic patients do not?
That's a great question. So it's likely because of the actual, now I'm kind of, I don't know the microbiology as well, but my guess would be, so our asthmatics have that type 2 inflammatory response. They have too many eosinophils, they have hyper-inflammatory component. So we're really trying to decrease that patient's own inflammatory response. In our structural lung disease patients, they don't have that. They just have open, floppy airways. And sure, there's some inflammation there, and maybe there's some EOs because there are patients with more EOs, but eosinophils. But because of that, so we're not necessarily directing it and decreasing a specific kind of inflammation unless that kind of inflammation is there. So when we add a corticosteroid, steroids in general can put everyone at risk of pneumonia, and more specifically older patients. So our COPDers are older, even some of our asthmatics are. I think the benefit to opening up the airways because you're decreasing the type 2 inflammation helps with improved airflow, and then you have less of an issue with like getting the obstruction and pneumonia related to that.
Thank you.
Okay, so the budesonide formoterol cost is about $400 or $500 a month. The budesonide alone is still $250. You mentioned the biologics are expensive. I have no idea what that is. So what do you mean by expensive?
So with insurance coverage, I have patients that are expected to pay $3,000 to $5,000 a month or something like that with
coverage.
With coverage. So but that depends on the insurance. And I have a lot of patients, if they are, some insurance covers it and it's like $500 or something even less monthly. And some of those doses are actually every other month. The Fasenra spaces out to every other month. But for patients who don't have as much means, there's a lot of support programs through AstraZeneca, through the companies, the actual drug companies. So most of my patients who are on it are paying nothing because they've gotten one of those free tickets. I don't know, I see Kristen's in the audience. She fields a lot of our patient calls for that, but it's somewhere in the thousands, potentially even with insurance.
Okay.
And then to speak to the inhaler price, that's limited me from being able to implement a lot of these recommendations, and that's something you're going to see commonly in primary care. So one way we're trying to get around that, and that's why the NIH guidelines are what they are, using an inhaled corticosteroid with a short-acting bronchodilator on top of it, because a lot of times you can get Flovent covered, and then you can just have the patient take Flovent with albuterol to be their combo as needed, or the Flovent twice a day with albuterol throughout. So that's, unfortunately, a lot of times I'm not implementing the GINA updates because of insurance reasons, and that's why the NIH updates are a little bit more focused on what our health system structure supports.
But unfortunately, the data shows that's not as effective.
It's not as effective. Yeah.
So I think one of your initial cases was a patient with an elevated hemidiaphragm. You know, we see that a lot I have a post-polio patient. I have people with, we don't know what caused it, but they've had it for years and then they develop shortness of breath. Do you think that's from the hemidiaphragm, or is that just something else?
When this guy, he did have airflow obstruction, and maybe he did the whole time, but it was never a problem until he was old enough and not strong enough to really deal with that elevated hemidiaphragm, because with time and age and fatigue. But the shortness of breath, I think people just hit a point where small ailments that used to not affect them are now going to affect them because they don't have as much reserve or conditioning to compensate.
Okay.
I do have one more question.
Jolene's got a question.
Thank you. Do you have any preference med among the meds from LAMA or LABA?
That's a good question. So most of the studies are budesonide, or so Pulmicort, so I end up using that a lot, especially like pregnancy. Symbicort and Dulera, I use them interchangeably. What I tend to be doing is I put them in Cerner, see if I get a green box or a red box. I put them both in and see, because sometimes Cerner can tell you if their insurance covers it or not. So I kind of play that game. Intermittently, I prescribe both and tell them pick up one from the pharmacy, pick up the cheapest. But sometimes neither of them are covered, sometimes you can't tell. But either using Symbicort or Dulera are recommended. Even if I'm using Advair, because Advair what's covered, I like the HFAs. So I like the hockey stick one, not the hockey puck. I just find the HFA to work better and give less thrush than the dried powder. Unless they're younger, then it doesn't really matter. As far as the llamas, I get frustrated with the llamas because Spiriva HandiHaler is really hard for my patients to open the packet. Even the Respimat, where it's a turn and push, it's just a lot of coordinating. So it's really frustrating. The one that's easiest to use is the Incruz Ellipta. And that's the one we use in the hospital when people are admitted. It's just a flip it open and take the inhalation, but it really depends on what's covered.
One more.
Okay, another one.
One more question, please. Any plans of office-based PFTs for primary care?
Oh, well, that is a great question. We would like PFTs everywhere. To be honest, office-based PFTs don't really give us as much information because quality of PFT coach, so the respiratory therapist who's telling you to blow, 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 really makes a difference in the quality of the PFTs. So we prefer it to be respiratory therapists doing it in PFT labs. So I think just on the fly spirometry is less valuable than things like exhaled fractional excretion of nitric oxide. I think if we started to use that in an institution and implemented that in primary care clinics, that'd be easier. It's a machine, you breathe. There's no coach that's needed, but it's a device and there's money start up there. But at this point, pulmonary function testing will stay in labs, and we have some spirometry like in Issaquah and other clinics, but we're hesitant to expand that really further because the quality and the information you get from that data is really dependent on your RT who's doing the procedure.
Thank you.
So I think I have to say one comment. Historically, I did see the word theophylline on your slide a couple times.
Yes.
And
We're still
I'm
using
surprised. I'm surprised that it's even there still. But that was 40, 30 years ago. That would have been the predominance of the lecture.
I have a couple patients on it still. We still use it now and then. But
All right. Thank you very much.
Thank you, guys.
Thanks.